My name is Stephanie Moo. I'm an orthopedic shoulder and elbow specialist here at Henry Ford West Bloomfield Hospital. Today, we're going to go over a patient that we plan on operating on tomorrow with an acute full-thickness rotator cuff tear. This patient is a 47-year-old right-hand dominant male who presented in my clinic approximately 2 weeks ago. Prior to presentation, he had a slip and fall at work where he works as a CRNA. Because of the immediate pain and disuse of his right arm, he was concerned about a rotator cuff tear and was seen by his workman's compensation doctor, where a MRI was obtained. He presented to my clinic with 10 out of 10 pain, very limited function. His physical exam was consistent with a full-thickness rotator cuff tear. He had limited range of motion, as well as a positive weakness with rotator cuff exams, as well as a positive Jobs and positive belly press test and a positive modified bear hug exam. So let's go over his radiographic images when he presented at my clinic. So here, part of my standard x-rays in my clinic include a Grassi as well as an axillary view. This is of the right shoulder, and as you can see, he has no evidence of any fractures or dislocations. He does, however, have some evidence of some AC joint arthritis. He does have also some narrowing of the inferior glenohumeral joint. On the axillary view, though, he does have a maintained space of the glenohumeral joint. So let's now take a look at the MRI studies. I start with the T2 coronal fat stat images. This is starting at the very front of his shoulder, working anteriorly to posteriorly. And as you can see, as I scroll posteriorly along the shoulder, we are starting to see evidence of the biceps tendon as well as the deltoid coming into view. And you can see a lot of edema consistent with a traumatic tear. As we start seeing the humeral head now, you can see this is the muscle belly of the supraspinatus tendon. And as you can see, there's discontinuity of where the tendon should be attaching to bone, suggestive of a very far anterior supraspinatus tear. As I continue to scroll, you can continue to see the defect with the increased high intensity signals, again suggestive of a tear. As we go more posteriorly into the infraspinatus tendon, while there are some signal changes, there's no evidence of a full thickness tear in the more posterior infraspinatus or teres minor tendons. My next set of images will be sagittal fat saturated images. And here we start on the far lateral side, working our way medially. So this is the lateral deltoid. And as I scroll medially, you start seeing the fibers of the deltoid becoming more prominent. And as I move continuously more medial, the humeral head has now come into play. As you can see here, these are the images of the rotator cuff in the sagittal plane, and there is a large defect, again anteriorly, and suggestive of an anterior supraspinatus tendon. As we continue to move more medially, you can see the remaining aspects of the infraspinatus and teres minor muscles are intact. I like to go as far medial as possible to also look at the muscle volume of the rotator cuff muscles. And as you can see in the supraspinatus muscle, there's not significant atrophy. The subscapularis muscle also does not have a significant atrophy. And again, as we look posteriorly, the infraspinatus and teres minor muscles also have no evidence of significant atrophy. So now I'd like to go to the normal sagittal images of the MRI. Again, we start laterally and work our way medially. And as we scroll medial, again, we start seeing the deltoid fibers, which are dark on this images, and the fat, which is lighter. As I move more medial, I'm running into the humeral head here. Again, if you look closely, there's a defect here suggestive of an anterior supraspinatus tear. The majority of his remaining rotator cuff appears intact. And these images are really good to look at the amount of fat atrophy and to be able to use our Goutalier's staging. So you want to go as medial as possible in your sagittal plane. Here we can get a good view of the muscle bellies. Anteriorly here, this patient has a very minor amount of atrophy, what I would consider a Goutalier's stage 1 of the superior subscapularis tendon, encircled here. If I look at his supraspinatus muscle belly, he also has some evidence of some fat streaking and volume loss. Again, I would consider this a Goutalier's stage of 1. Posteriorly, his infraspinatus muscle has no real evidence of any fat atrophy, and his teres minor also looks intact without evidence of atrophy. So finally, I like to look at the axial images to get a better look at my subscapularis and teres minor tendons. In these images, we start at the top, working our way inferiorly. So this is the top of the shoulder here, and as I scroll inferiorly, you can start seeing some bone of the clavicle and the acromion coming into play. And as I scroll again more inferiorly, I'm starting to see the muscle tendons. Here's the muscle belly of the infraspinatus tendon attaching nicely onto the greater tuberosity. And this patient has a full thickness tear of the superior subscapularis tendon. You can see the tendon is retracted almost to the articular surface of the humeral head. As I scroll inferiorly, the inferior aspect of the tendon seems to be intact. So based on the patient's presenting symptoms, clinical exam findings, as well as radiographic images, I propose to the patient we perform an arthroscopic rotator cuff repair and subacromial decompression. So let's go to surgery.